Now I just want to say a couple of special things about second generation. We said the drugs that we want to remember is quetiapine, olanzapine. Olanzapine is very famous because it has one of the highest risks of metabolic syndrome. That's very characteristic for olanzapine. Now another drug that I wanted to mention is clozapine. Clozapine has also dopamine antagonism and serotonergic antagonism, but may do other things as well. Sometimes referred as the best and the worst in one drug. Why is that? This is probably the most efficacious drug for schizophrenia, and it's very good in treating the negative symptoms. It's probably the best in treating the negative symptoms, but it has tons of black box warning. It's a pretty dangerous drug. Why? One thing it can cause, and it's a black box warning, so that stands BBW, it can cause agranulocytosis. So that stands for A without granulocytes. So granulocytes are cells of the immune system that are very important for you to defend against infections. So if you have someone that develops agranulocytosis, you may succumb to an infection. So that's obviously dangerous. And if you put someone on this drug, you need to always do your white blood cell count to make sure that you're not going to develop agranulocytosis. There are tons of other black box warning. Another famous one, it increases the risk for seizures. So you can never give that to someone with an underlying seizure disorder. And then a good thing about clozapine, why it's also considered the best, I mean, because of the clearly effective drug in treating negative symptoms, and also the best because it causes no EPS. So there's so far no single report of someone got EPS on clozapine. So that's also very good. Because of all these problems, it's right now only used indication for treatment-resistant schizophrenia. So you're not going to give that as a first line to someone. Only if you have tried a couple of drugs. And last, I wanted to say a couple of words about the piprazoles. And here a nice example to remember is this aripiprazole. So these are the piprazoles. These are our newer second generation, so they don't follow the typical thing about dopamine antagonism, serotonergic antagonism. They are actually partial dopamine agonists. Partial dopamine agonists. What does that mean? Well, that means they're partially activating the dopamine receptor. They're tickling the dopamine receptor. Why would that help? Well, you know that a partial agonist acts as an antagonist in the presence of a full agonist. So imagine you have in your mesolimbic pathway full stimulation of these dopaminergic receptors because a patient has schizophrenia, and now you add a partial dopamine agonist. Well, then this competes for the full stimulation of the dopamine in the patient. So that means that gives you some sort of blockade because it's not going to be a full agonist. And then the additional advantage is that you may not see as severe EPS because you're still tickling the dopamine receptor. You're not just completely blocking it. So that's aripiprazole. I just want to say one last thing, which is true for all of the antipsychotics. They have a black box warning, all of them, that they increase mortality in elderly patients with dementia. And that's something important to know because they are sometimes used in this population, and they shouldn't. They increase mortality. So that's as a last thought, which is true for all of the antipsychotics. Thanks for watching this video on the pharmacology of the antipsychotics. Bye-bye.